So hi guys, good evening to today's session. Today we are here to talk to you about the Snaps and Surgery episode 2, where we'll be dealing with the endocrine surgery. So I hope I'm audible to you and my screen is visible to you. I might not be visible to you, but that's fine. I guess the screen is visible to you. So great, I'm getting the confirmation. And yeah, so let's begin guys, let's begin. So good to have all of you guys with me over here. So without wasting any further time, let us start with the first thing. So here you have a kind of a child who is presenting to you. Let's say the age of the child is around, okay, so let's take the age of the child is around, let's say, okay, let's put it as like 15 years, and the child is coming to you with a midline swelling. And the characteristics of this particular midline swelling is that it moves up and down with the deglutination. Okay, with the deglutination, this particular swelling is kind of moving up and down. So what is the diagnosis, guys? What is the diagnosis? Here you have a kind of a child who is around 15 years of age. The child is coming to you with a midline swelling, and this particular swelling is moving up and down with the deglutination. What is the diagnosis? Absolutely no doubt. The answer to this particular thing is that this particular child is suffering from a thyroglossal cyst. What is the child suffering from? The child is suffering from a thyroglossal cyst. Now let us talk about this particular stuff. So let us kind of discuss a few points regarding the thyroglossal cyst. So what is the cause of it? Can you please let me know what is the cause of this particular stuff? So it is a congenital deformity, right? So it is, what is the cause? Cause is basically, it is a congenital remnant. So here there is basically a persistence of thyroglossal duct. So what is happening normally is, normally you have this kind of a tongue, and from the base of the tongue you get a thyroglossal duct. This thyroglossal duct comes to the neck and leads to the formation of a thyroid gland, and once it has led to the formation of a thyroid gland, what is going to happen? It is going to disintegrate. Okay, so it is basically going to go away. Okay, but if at all, let's say this particular thyroglossal duct, it doesn't go away and there is a persistence of this thyroglossal duct at one particular point, it can lead to the formation of a cystic lesion, and this is what you refer to as a thyroglossal cyst. Now the first most important point which you need to remember about this is, what is the most common site? So if I just ask you what is the most common site of this thyroglossal cyst, the most common site of this thyroglossal cyst is, it is present at the subhyoid region. Okay, so the most common site, it is a subhyoid, that is, it is basically present just below the hyoid bone. Okay, that is the most common site. Now okay, another important point which you need to tell me is that how will you diagnose it? So as I was telling you, in this particular scenario, the clinical features was, there was a midline swelling. Okay, so there was a midline swelling, and this swelling was basically mobile. It was basically moving with the deglutination. Okay, it was moving with deglutination. So this is something which is giving you a diagnosis of a thyroglossal cyst. Okay, yep, got it, right. So these are the important points regarding thyroglossal cyst. Now if I just ask you, do you need to treat it? Okay, treatment, is it required? Can you please tell me, is it needed? The answer is yes, you need to treat it. The answer is yes. Why? Because it may complicate. So what are the complications which can occur if you do not treat this particular stuff? Is the complications which can occur is that it can get infected, and worst part is it can develop a malignancy. Now this is a very important MCQ. If I just ask you, what is a malignancy which can occur in this particular thing? Okay, so what is a malignancy which can occur in this? It can come to you with the papillary carcinoma of thyroid. Okay, so the most common malignancy which can occur is a papillary carcinoma of the thyroid. Okay, I hope you get this point. Very important, and that is why you need to treat it. And okay, if you want to treat it, what is the name of the surgery? You have to go in for a surgery. What is the name of the surgery? It is a cyst trunk operation. Okay, what do you need to go in for? You need to go in for a cyst trunk operation. Cyst trunk operation. So guys, I know that this was a very simple topic and I've just tried to revise it for you guys. I hope you kind of understood this particular topic. I'll just kind of summarize what I told you. I told you that there is a thyroglossal duct which arises from the base of the tongue, comes to the neck, lead to the formation of a kind of a thyroid gland, and once this particular job is done, this thyroglossal kind of duct needs to go away. It needs to disintegrate. But if at all it persists, it doesn't go away. If at all this happens, it might lead to a formation of a cystic lesion, which you call it as a thyroglossal cyst. The most common site is, it will occur in the subhyoid region. That is the most common site. Important MCQ. How will you come to know whether this is a thyroglossal cyst and no other swelling? Because it is, if at all it is a midline swelling and it is moving with deglutination. These are the 2 points which will be in the favor of a thyroglossal cyst. Then I told you that you need to treat them. Why do you want to treat them? Because if you don't, it will complicate. What are the complications which can occur? It can lead to the infection. It can lead to the malignancy. A very important MCQ is that, which is a malignancy which can develop. So papillary calcium of thyroid is an important malignancy which can develop. And lastly, if you want to treat it, so you will have to go in for a surgical excision by the name of a cyst trunk operation. Okay, I hope you get this particular point. Now let's move on to the next thing. So here you had a kind of a patient who came to you with the thyroid swelling. Now whenever a patient is coming to you with thyroid swelling, the investigation of choice is an FNAC. So you were a kind of a good doctor and you did an FNAC in this particular patient, and the FNAC report came out to be like this. So if I just ask you, what is the diagnosis of this particular patient? So I hope you got to my point, right? So let's kind of, to make it interesting, let's give you a scenario where there is, let's say, a 40-year-old female who is coming to you with a thyroid swelling, and when you basically did a FNAC of this particular patient, you saw that this is a slide which you saw. Okay, so now can you please tell me guys, what is the diagnosis of this particular patient? Now if you're thinking that this particular patient is suffering from a papillary carcinoma of thyroid, you are absolutely correct guys. Okay, you are absolutely correct. So if I just ask you, okay, right, so if I just ask you, what are the FNAC features? Okay, what are the FNAC features which you basically get in the papillary carcinoma of thyroid? Okay, so what are the FNAC features which you will get in the papillary carcinoma of thyroid? So yes, you will get an orphan NEI nuclei, So what is this? This, I hope you're able to appreciate, these are the cells, right? But are you able to see the nuclei in them? No, right? They are appearing as an empty. So this has been taken from a cartoon character where again the eye was there, but it was kind of an empty. So it is just a kind of acronym for that. I hope you get this. That is what you call as a orphan NEI nuclei. Please understand this. This is a very important feature which you get on the FNAC of a papillary carcinoma of thyroid. Along with this, what you can have? You can have something which is called as a pseudo grooving. So what do you understand by pseudo grooving guys? Let's say this is the cell membrane of a cell. Now this is kind of normal, right? Sometimes what can happen is this cell membrane can invaginate on itself. Now this is not an actual groove, but on the kind of cross section this might appear like a groove. So this is what is called as a pseudo grooving. So just understand, nothing great about it, but just you need to understand that pseudo grooving is a feature which you might get in the papillary carcinoma of thyroid. And lastly, you will definitely get somoma bodies. Okay, so you will get somoma bodies. Now I know that whoever is watching this, you're very kind of sure where are the other places we get the somoma bodies. But if I may, can you please let me know guys, what are the other places or the other pathological conditions where you might find a somoma body? Okay, now if you don't know, that's fine. I'll just give you a simple mnemonic. It is basically based on your favorite subject, that is a PSM, right? Okay, so what is a mnemonic? You get it in the papillary carcinoma. So you basically get in the papillary carcinoma of the thyroid, which we are basically seeing, and at the same time you can also get it in the papillary renal cell carcinoma. You get it in the serous cystadenoma of ovary, and you get it in the meningioma. Now I know most of you guys must be knowing this, but if you don't, just remember it. These are the kind of 4 main places where you basically get a stoma bodies. Okay, great. Right, so these are the affinity features which I wish to cover in the papillary carcinoma of thyroid. Okay, so now let us move on, and now let us talk about the thyroid scan. But before I talk about the thyroid scan, I want to know something. So I want to know that what do you feel about the thyroid scan. So if I just ask you a simple question, right, is can we come to know, like if at all I perform a thyroid scan in a patient who is having, let's say, a thyroid lesion, after the, like when I get the result of a thyroid scan, can I say that this particular patient is suffering from a malignancy and this particular patient is not suffering from a malignancy? Can I do that? Yep. Can I just have an answer like yes or no or something? So what I'm trying to ask you is that if at all you perform a thyroid scan in any person who is having, let's say, a thyroid lesion, at the end of the scan, can I know that this particular patient is suffering from a thyroid malignancy and this particular patient is not suffering from a thyroid malignancy? The answer is no, guys. Okay, so it is a common misconception that thyroid scan tells us and helps us distinguish between the thyroid malignancy. It is no. Okay, please understand, thyroid scan, it cannot tell if a thyroid lesion is malignant or not. It cannot tell that. Okay, please understand this. Okay, so thyroid scan, it cannot tell you whether this particular kind of a lesion is a malignant or not a malignant lesion. Then what do you get from the thyroid scan? What do you get? It can only tell, it can tell if a lesion is hyperactive or hypoactive. Are you understanding my point? So we cannot come to know whether this particular lesion is malignant or not. All we can come to know is that, is this particular lesion having an increased activity or is that particular lesion having a reduced activity? That is what we come to know from a thyroid scan. So I hope you got this. This is a common misconception which the students have. So I hope that's kind of out of the window now. Now you have a kind of an image of a thyroid scan over here. So let's say again, this is, let's say, a 40-year-old female who is coming to you. Okay, so you performed a thyroid scan in this particular patient and you get to know, you got this particular image. What do you think, guys? What is this particular patient suffering from? You need to tell me whether it is a hot nodule or whether it is a kind of whether it is a hot nodule or whether it is a kind of a cold nodule, and what you need to tell me, what is a provisional diagnosis which you have of this. Okay, so can you please let me know, guys? Yep. So guys, in this particular patient, what you're basically seeing is that if at all you complete this particular thyroid gland over here, so you are having that one particular part of a thyroid is having an increased uptake. So well, yes, this is a patient who is having a hot nodule. And if I just ask you what is a provisional diagnosis, obviously you cannot tell me with certainty, but yeah, most probably this particular patient is suffering from, it is not the Graves' disease. Okay, Samriddha, okay, good try, but it is not a kind of a Graves' disease. Why? You only will tell me why. Okay, so the provisional diagnosis is basically a toxic adenoma. Okay, it is a toxic adenoma. Now Samriddha said that it is a Graves' disease. Well, it is not. I mean, you know, yeah, it is not a Graves' disease. Why? Because if it would have been a Graves' disease, the entire thyroid gland would have an increased activity. But no, here the entire gland is not having a kind of increased activity. Only a part of a thyroid gland is having increased activity. So I hope you got your answer, Samriddha. Why it is not a Graves' disease? Because it is only a part of a thyroid gland which is having an increased activity, not the entire gland. Okay. Yep. I hope you get this. Right. Okay, right, that's about the thyroid scan. Now, okay, now this is a kind of a image which is going to help you in remembering the thyroid scan. So once you do a thyroid scan in any patient who is having a thyroid lesion, at the end of the scan you can get 3 reports. Either it is the person having a cold nodule, is the person having a warm nodule, or is the person having a hot nodule. That is what you will basically come to know. Now, if at all there is a lesion in a thyroid gland, and if at all the uptake of that particular lesion is less as compared to the rest of a thyroid gland, this is a person who is having a cold nodule. If let's say there is a thyroid nodule, but the uptake of that particular nodule is same as compared to the rest of a thyroid gland, the person is having a warm nodule. And let's say if at all there is a thyroid nodule, which was the case, which in the first image which I showed you, if at all this particular nodule is having an increased uptake as compared to the rest of a thyroid gland, then the diagnosis is it is a hot nodule. So I hope you are able to appreciate. There is a schematic diagram also which is given just below these particular lesions for your better understanding. Okay, so I hope you get this particular point right. Okay, so at the end of a kind of a thyroid scan, you might get whether it is a cold nodule, whether it is a warm nodule, or whether it is a hot nodule. Now another important thing which you need to remember is that if at all you get a cold nodule, what is the risk of malignancy in this? What is the risk of malignancy? So very important MCQ guys. If at all you get a cold nodule, the risk of malignancy is 15 to 20%. Please remember this. Okay, it means that if at all you have 100 patients who are coming to you with a report of a cold nodule of a thyroid, out of those 15 to 20 patients will have a thyroid malignancy. In the similar manner, if at all there is a warm, like a hot nodule, the risk of malignancy in these particular patients, the risk of malignancy which you will get in these particular patients is, it is around 3 to 5%. So I hope I made my point. If at all a patient is having a cold nodule, the chances of that particular patient to have a thyroid malignancy, that is more as compared to that of a hot nodule. But it doesn't mean that if at all the patient is having a cold nodule, 100% there is a malignancy. That is not true. I hope you get this. It is very simple. I hope you have understood this, right? Okay, so what I have done is I have just tried to make you understand the thyroid scan. I'll just quickly revise it. In the thyroid scan, what did I tell you? That it cannot tell you whether that particular lesion is a malignant or not. All it can tell you that if that particular lesion is having an increased activity or a reduced activity. So once you perform a thyroid scan, you can have three types of lesions. If at all that particular thyroid lesion is having reduced activity as compared to the rest of a thyroid gland, you diagnose it as a cold nodule. If at all that particular lesion is having the same activity as of the rest of a thyroid gland, you diagnose it as a warm nodule. And if at all that particular lesion is having more activity as compared to the rest of a thyroid gland, you diagnose it as a hot nodule. If at all there is a hot nodule, the risk of malignancy is 3 to 5%. If at all there is a cold nodule, the risk of malignancy is 15 to 20%. And in this particular image which I had shown you, it is definitely a hot nodule, and most probably this particular patient is suffering from a toxic adenoma. Why is it not a Graves' disease? Because in the Graves' disease, the entire thyroid gland will have an increased activity. Okay, so I hope I have made myself clear, right? Okay, great. Now let us move on and let us talk about the next image. So what do you have, guys? Here you have a kind of a guy, like not a guy, a man who is basically just sitting in front of you, and all is fine, like everything is fine, no problem at all. Then what do? You ask this particular patient to lift the kind of his arms above his kind of ears, and then something happens to his face. So if I just ask you, by looking at this particular image, what is the diagnosis which comes to your mind? Okay, so what is the diagnosis which basically comes to your mind, guys? Can you please help me with this? What is the diagnosis? Okay, so I'll just repeat. What happened was, the kind of a guy, this particular man walked to your clinic, and you observed this particular man. Okay, then you asked, like when he was sitting there talking to you, everything was fine. You asked this particular man to kind of lift his arms above his head, and then something happened to his face. Okay, what is the diagnosis of this particular patient? Okay, if you would say that this is a patient who is suffering from a retrosternal goiter, retrosternal goiter, you will be absolutely correct, guys. Okay, why? What is this particular sign? The sign which I just demonstrated to you in the last image, it is called as the Pemberton sign. Pemberton sign. Now this Pemberton sign, as you know, that this is basically present in the retrosternal goiter. Now what is this Pemberton sign, guys? What is this Pemberton sign? Pemberton sign means that there is a development of a facial plethora. Facial plethora develops when the man is asked to lift arms above the head level. So why this is happening, guys, when the kind of man was just sitting to you in front of you and all was fine, the thyroid gland was still there, it was obstructing your thyroid inlet, but it was okay, like the space was still there. As soon as you ask this particular man to lift the arms above his head, this particular space, which is basically present in this neck region, it basically reduces even further. And because of this, what happens, the vessels which are draining the blood from the head, they are compressed, and because of this you get a characteristic facial plethora. What do you get? You get a facial plethora. So this is something which is kind of a diagnostic of a kind of a retrosternal goiter, and this particular sign is referred to as a Pemberton sign. Okay, yeah, all cool, right? So now let us kind of discuss a bit about the retrosternal goiter. So I would just ask you, it can be either primary or it can be secondary. Okay, so retrosternal goiter, it can be either primary or it can be secondary. Out of this, guys, what do you think, which is more common? Primary retrosternal goiter is more common, or the secondary retrosternal goiter is more common? Now if you say that the secondary retrosternal goiter is more common, you are absolutely correct, guys. Around 90% of the retrosternal goiter is a secondary and only 10% is the primary. Okay, please remember this. Now what do I mean by a primary retrosternal goiter, guys? Primary retrosternal goiter means that it started its development in the thorax. On the other hand, the secondary retrosternal goiter, it basically started the development in the neck and then it came to lie in the thorax. Okay, so I hope I'm clear, guys. The primary retrosternal goiter is something which started, like it primarily started to develop in the thoracic cavity, but the secondary retrosternal goiter, it means that it started its development in the neck and then it gradually descended down and then came to lie in the thoracic cavity. Now the point is, why do you want to know this? Why do you want to distinguish between these? Because in the primary retrosternal goiter, it will have the mediastinal vessels which will be supplying it, and because of this, for the treatment you will have to go in for a thoracotomy. Okay, so thoracotomy will be needed in the treatment of this primary retrosternal goiter. On the other hand, in the secondary retrosternal goiter, it is usually going to have the cervical vessels, and because it is having the cervical vessels, for the treatment you will just need a kind of a, you just need to control the cervical vessels. Okay, thoracotomy is not needed, you can just go in for a cervical incision is enough. Okay, I hope I have made my point, guys. Here what is happening, in the secondary retrosternal goiter, the kind of the development started in the neck, so the blood supply which it received was from the cervical vessels, and because of this, even if you just give a cervical incision, that is kind of more than enough for this particular patient. Okay, I hope you got this. So now the last question for the day is, guys, here you have a kind of a, let's say, a child who is having X-ray finding like this. Okay, so you are basically having X-ray finding. I'll just zoom it over here. So this is what you are having in the X-ray finding. Now you basically did the labs of this particular patient and there was hypercalcemia which was present. Hypercalcemia was present and the parathyroid hormone was also increased. Okay, so there's a child who is coming to with a hypercalcemia and the hyperparathyroidism, and you have the tufting of the kind of distal phalanx. What you're basically seeing in over here, this is what is referred to as a tufting of distal phalanx. Okay, so what I want to ask you is, guys, what is the diagnosis of this particular patient? So can you please help me? What is the diagnosis? Yeah, what is the diagnosis, guys? So in this particular patient, what you're having is the diagnosis is of, okay, cool. What is the diagnosis? The diagnosis is of a primary hyperparathyroidism. Okay, I hope you get this, guys. Okay, so in the primary hyperparathyroidism, there are a couple of findings which you get on the bone. So if I just ask you, in the primary hyperparathyroidism, what are the features which you get in the bone? Okay, if you have a look at this particular bone, what are the features which you get, guys? So here you get something which is called as a osteitis fibrosa cystica. So because of the demineralization of the bones, there is a kind of a tumor-like formation in the kind of a distal ends of the bones, which is referred to as a osteitis fibrosa cystica. And this is again a very, very characteristic feature of a primary hyperparathyroidism. Along with this, you can get a tufting of distal phalanx. Okay, you can get a tufting of a distal phalanx. As you're able to see, it means that the terminal phalanx, it is kind of tufted, it is kind of a broken. That is what is also referred to as a acroosteolysis. Okay, it is also referred to as a acroosteolysis. It means that the terminal portion of this particular kind of a phalanx, it is kind of lysed away, it has kind of broken away. That is what you mean by a acroosteolysis. That is something which is referred to as a tufting of a distal phalanx. I hope you got this. These are the bony findings which you get in the primary hyperparathyroidism. Okay, that's it, guys. That's it for today. I hope you kind of enjoyed this particular session. I hope you like this, and if you're liking these particular sessions, guys, definitely you're going to like our Plus platform. I'm just trying to inform you that I'm coming up with a general surgery revision via MCQ. So in this is basically, I would like to call it as a talking Q bank. Now in this, what I'm going to do is that in 44 hours, the entire general surgery is going to get covered. Okay, entire general surgery is going to get covered, and I would discuss close to around 2000 MCQs in this. Okay, so close to 2000 MCQs will be discussed in the 44 hours, and the entire general surgery will be covered in the form of an MCQs. So this particular kind of a course which will be taken up by me, that is Dr. Pawan, this is going to start on the 1st of September. So if you are already a Plus subscriber, please stay tuned. It is going to start from the 1st of September. If you're not a Plus subscriber, you can definitely come and attend it. Like if at all you're interested in this particular course and any of the other courses by so many great educators on the kind of an academy platform, you can just browse through them, and if at all any of these particular courses interests you, you can definitely come and experience our Plus platform. I'm sure you're going to like it. Right. And if at all you decide to join and you are not a kind of a Plus subscriber till date, you can try to use my promo code, that is tr.pawan. If you use it, you will get 10% off on whatever the subscription which you basically take. Okay, that's something which I just wish to tell you. But yeah, I mean, if at all you're a Plus subscriber, please don't miss this, guys. Yeah, please don't miss this. This is something which is going to be helpful for you a long way, right? I hope you will kind of come and attend it if at all you are a Plus subscriber. If you're not, do consider taking a Plus subscription. That's it, guys. Thank you so much. It was indeed a pleasure interacting with all of you guys, and yeah, keep calm and happy studying. The exams are nearing, but don't panic, just keep on studying. If you have anything to ask me, if you want to ask me something, you can definitely ask me in the comment box. If not, that's fine, that's completely cool, and I'll see you next time. Yeah, I'll definitely see you soon. So yeah, if at all you want to know the schedule of my upcoming classes, so I'm going to take the session on 21st. Okay, so 20th and 21st. Okay, 20th and 21st, but that is going to be in the morning, guys. In the morning, we are going to have like the session from 9 a.m. and at 10 a.m. So I'm going to have two sessions every day on 20th and 21st. So if at all you are free and if at all you want to discuss some certain MCQs with me, these are going to be the MCQ discussion sessions. So if at all you want to come and join me, please do join me on 20th and 21st morning. 9 a.m. is the first session, and then just after a break of 5 to 10 minutes at 10 a.m. we will be having the second session. Okay, that's it, guys. Thank you so much. It was indeed a pleasure interacting with you. Have a great day and happy studying. See you. Bye.